Lesson number 9, the primary assessment. In previous chapters, you learned how to prepare for an emergency, the precautions to take when approaching the scene, and how to recognize a dangerous situation. You also learned about your roles and responsibilities. As an emergency medical responder, you can make a difference in an emergency. You may even save a life. But to do this, you must learn how to provide care for an injured or ill person and set priorities for that care. Okay, right here we have a scenario that we will discuss in person, okay? You are the emergency medical responder. Your rescue unit arrives at a scene to find a distraught mother who says, "I can't wake my baby up." The infant appears to be unconscious and is turning blue. Okay, so just think about this scenario and how you would approach this situation, okay? We will discuss this in person. Okay, primary assessment. When an emergency occurs, one of the most essential aspects of your job is the primary assessment. The primary assessment is the process used to quickly identify those conditions that represent an immediate threat to the patient's life, so that you may properly treat them as they are found. An effective primary assessment includes creating a general impression of the patient, checking for responsiveness, and checking airway, breathing, and circulatory status. So check for conditions that are immediate threat to the person's life, okay? General impression, level of consciousness, breathing, and circulation. Okay, our next slide here is sizing up the scene. Okay. Once you recognize that an emergency has occurred and decide to act, always remember the importance of sizing up the scene first. A primary assessment should never occur until after the scene size up. The 4 main components to consider during a scene size up include scene safety. Number 2, mechanism of injury or nature of illness. Number 3, the number of patients involved. And number 4, the resources needed. Okay, here's an activity. You are called to the home of an older woman. Her daughter arrived at the home and found her mother lying on the kitchen floor, moaning in pain and unable to move. The older woman is lying face down on the floor, pointing to her right leg and mumbling that it hurts terribly. She is wearing a bathrobe and socks. There are numerous bottles of pills on the kitchen counter near the woman. There is also a small kitchen throw rug that is crumpled up near the doorway. The woman's slippers are under the kitchen table. Okay, so just think about this scenario and how you would handle this situation. Okay, and this is a scenario that we will discuss in person. Okay, our next slide here is dealing with summoning more advanced medical personnel. Okay. At times, you may be unsure if more advanced medical personnel are needed. For example, the patient may ask you not to call an ambulance or transport vehicle to avoid embarrassment about creating a scene. Your training as an EMR will help you make a decision. As a general rule, summon more advanced medical personnel for any of the following conditions, okay? Unconsciousness or altered level of consciousness, or a brief loss of consciousness, okay? Breathing problems, difficulty breathing or no breathing. Chest pain, discomfort or pressure lasting more than a few minutes that goes away and comes back, or that radiates to the shoulder, arm, neck, jaw, stomach, or back. Persistent abdominal pain or pressure. No pulse. Or severe life-threatening bleeding, bleeding that spurts or gushes steadily from a wound. So in other words, even if someone is saying, they don't want more advanced emergency medical response in this situation, we're going to call anyway. They could always turn it down later, but in extreme cases when somebody might have a really life-threatening type of issue, we don't allow them to intimidate us from making that call for their best interest, okay? So this is summoning more advanced medical personnel continued, okay? So we have vomiting blood or passing blood, okay? That's an indication of something serious. Severe critical burns, okay? Suspected poisoning, seizures, stroke. Sudden weakness on one side of the face, facial droop, sudden weakness on one side of the body, sudden slurred speech or trouble getting words out, or a sudden severe headache. Suspected or obvious injuries to the head, neck, or spine, painful, swollen, deformed areas, suspected broken bone or an open fracture, okay? It is impossible to provide a complete or definitive list. There are always exceptions. Trust your instincts and follow local protocols. It is better to have more advanced medical personnel respond to a non-emergency than arrive at an emergency too late to help, okay? So, in other words, it's better to be safe than sorry. Now here we have establishing responsiveness, okay? What happened? What's your name? Where are you? What day of the week is it? These are questions you can ask that someone who's in the right state of mind will typically know, right? Most people know. And if they can't answer these questions, then you might want to look deeper into what might be going on with this individual, because these are questions that the majority of adults would know, okay? Establishing responsiveness. When approaching a patient, check for responsiveness and assess their level of consciousness. This can range from being fully alert to being unconscious and unresponsive to any stimuli such as voice or pain. First, speak to the patient. This may be to warm the patient to remain still if there is a situation that could cause damage to the head, neck, or spine. For example, in a motor vehicle collision or a fall off a ladder, the patient would need to remain still. Identify yourself as a responder and state that you are there to help. Obtain consent from the patient before beginning the primary assessment and providing care. When approaching a patient, you should try to approach from the front so that the patient can see you without needing to turn their head. This is especially important in the case of a suspected head, neck, or spinal injury. Okay, on the next slide here, we have the acronym AVPU, AVPU, okay? So first we're going to deal with, in describing a patient's level of consciousness, a 4-level mnemonic scale is traditionally used, referred to as AVPU, AVPU. The letters A, V, P, and U each refer to a stage of awareness. Okay. Let's first deal with alert. Patients who are alert are conscious and aware of their surroundings, able to acknowledge your presence and able to respond to your questions. Verbal. Sometimes the patient is only able to react to sounds, such as your voice. The patient's eyes may be closed, but they open when hearing your voice or when the patient is told to open them. The patient may appear to be lapsing into unconsciousness. A patient who has to be stimulated by sound to respond is described as responding to verbal stimuli. Painful. A patient who does not respond to verbal stimuli or commands, but does respond when someone inflicts pain, is described as responding to painful stimuli. Pinching the earlobe or the skin above the collarbone are examples of painful stimuli used to try to get a response. Be cautious, however, about pinching the earlobe in patients who may have neck trauma, as they may try to move their head away from an irritating stimulus. Instead, forcefully pinch or squeeze the fleshy section of skin between the patient's thumb and forefinger. Now let's discuss the U, unresponsive. Patients who do not respond to any stimuli are described as being unconscious or unresponsive to stimuli. Okay? Okay, now we're going to deal with airway status. Okay? The pathway for air passage between the mouth and nose to the lungs is called the airway. Without an open airway, the patient cannot breathe. A patient who can speak or cry is conscious, has an open airway, is breathing, and has a pulse. However, the patient may still be at risk of a comprised airway. Assess the airway with the unconscious patient face up. First, verify if the airway is patent, open and clear. If the patient is breathing, chest is rising and falling with air moving in and out, or the patient is speaking to you and aware of the surroundings. Then you need to ensure that the airway remains open and clear. Continue to assess the patient's respiratory status throughout the period that you provide care. The airway can become blocked by fluids, solid objects, the tongue, or swollen tissue caused by trauma or severe allergic reaction. Determine whether there is a need for any interventions to establish or maintain patency. For example, does the patient require suctioning to remove fluids or a finger sweep to remove solid objects or debris? Will an oral or nasal airway be necessary to prevent the tongue from falling back in the throat and blocking the airway? If the patient is wearing dentures, leave them in place unless they become loose and block the airway. Dentures help support the patient's mouth and cheeks, making it easier to seal the resuscitation mask if you need to provide ventilations. Okay? So to address these slides here, without an airway, a patient cannot breathe. Okay? A patient who is speaking or crying is conscious, has an open airway, is breathing, and has a pulse, but they may still be at risk for a compromised airway. So that shows that they do have an airway, but it can be compromised. Establishing and maintaining an open airway for an unconscious patient may include suctioning or using finger sweeps or an oral airway. Okay? Dentures are left in place unless they become loose and block the airway. Opening the airway. It is more difficult to tell if an unconscious patient has an open airway. To open the airway for a patient who has not suffered any injury to the head, neck, or spine, open and maintain the airway using the head tilt chin lift maneuver. For patients of all ages, tilt the head back and lift the chin to open the airway. Do not tilt a child or infant's head back as far as an adult's. Tilting the head back too far can close off a child's airway. Tilt a child's head so the airway is slightly past neutral position, and tilt an infant's head so the airway is in neutral position. To open the airway with the head tilt chin lift maneuver, kneel beside the patient's head and neck. Place one hand on the patient's forehead. Place the fingertips of 2 or 3 fingers of your other hand under the bony part of the patient's lower jaw near the chin. If the patient is a child or an infant, use only 1 or 2 fingers. Use firm backward pressure from the palm of your hand to tilt the head back while lifting the jaw up with the fingertips to extend the chin forward. If the patient is a child, tilt the head so the airway is only slightly past neutral. For an infant, tilt the head so the airway is in a neutral position. Keep pressure on the patient's forehead to help maintain the airway in an open position. Okay. So now we're going to deal with the jaw thrust without head extension maneuver when there is a suspected head, neck, or spinal injury. To open the airway for someone who has a suspected head, neck, or spinal injury, use the jaw thrust without head extension maneuver. To keep the head and neck in a neutral position, this maneuver moves the tongue away from the back of the throat, allowing air to enter the lungs without moving the head and neck. After opening the airway, look, listen, and feel for breathing. Do not move the head to the side, forward, or back. You can perform this maneuver with or without a resuscitation mask. Note that if you could not establish an open airway using the jaw thrust without head extension maneuver, use the head tilt chin lift maneuver instead. For step-by-step instructions on performing the jaw thrust without head extension maneuver, see skills sheet 7-2. Okay? Okay, now we're going to discuss breathing status. If the patient is breathing, the chest will rise and fall. However, you must also listen and feel for signs of breathing. Position your ear over the patient's mouth and nose so you can hear and feel air as it escapes. At the same time, look for the chest to rise and fall. Look, listen, and feel for breathing for at least 5 seconds, but no more than 10 seconds. You will simultaneously check for breathing in a pulse. Pulse checks will be discussed later in the chapter. Check the patient's neck to see if they breathe through a stoma. A stoma is an opening in the neck to allow a person to breathe after surgery to remove part of all the larynx, voice box, or other structures of the airway. The person may breathe partially through this opening or may breathe entirely through the stoma instead of through the nose and mouth. Use round pediatric mags if you need to provide ventilations. Okay. Now, look, listen, and feel for effective breathing with your ear positioned over the patient's mouth and nose while checking for a pulse for at least 5 seconds, but no more than 10 seconds. In an unconscious adult, you may detect isolated or infrequent gasping, agonal breaths, which can occur after the heart has stopped beating. Agonal breaths are not breathing. Care for the patient as if there is no breathing at all. Okay, on the next slide here, we are going to deal with breathing rates. If the patient is breathing, assess the rate and depth of the breathing. A healthy adult breathes regularly, quietly, and effortlessly. Okay, so we're going to right now talk about the normal breathing rates. Okay, adults. So 12 to 20 breaths per minute. That's a normal breathing rate for an adult. For children, 15 to 30 breaths per minute. For infants, 25 to 50 breaths per minute is normal. So for abnormal breathing for adults, 18 to 20 breaths per minute. You see that's kind of low. Children, 10 to 30 breaths per minute. Infants, 20 or 60 breaths per minute is considered abnormal. Okay, next slide. We're going to be discussing the use of supplemental oxygen or ventilations. Administer supplemental oxygen or provide ventilations as appropriate. Based on local protocols, if the patient is having trouble breathing, this would be necessary if the patient is unresponsive. Monitor the patient's airway to ensure that respirations are continuing and effective. Hypoxic. Pale, cool, clammy, moist skin is an early sign of inadequate oxygen. Cyanotic. The patient is not receiving adequate oxygen. This is a clear but late sign of inadequate oxygen. The mouth, lips, and nail beds would appear blue in color. Breathing very shallow respirations. The patient is likely not receiving an adequate supply of oxygen. Breathing increasingly slow. Oxygen intake will be dropped and the patient is likely not receiving an adequate supply of oxygen. Tolerant of assisted ventilation. For those who are not tolerant of assisted ventilation, you can use a blow-by technique. Okay, so slide 128, we're dealing with vital signs, okay? Consciousness, breathing, and circulation, including pulse and skin characteristics, are called vital signs. They are sometimes referred to as signs of life. Check the vital signs often as you monitor a patient while you wait for more advanced medical personnel to take over. Assess the patient to determine if it's a life-threatening condition. If the patient is unstable, Care for the life-threatening condition as soon as it is discovered. For stable patients, vital signs with normal range, assess the patient's condition and provide care as necessary. Patients who are unstable should be reassessed at least every 5 minutes or more, often if indicated by the patient's condition. Reassess stable patients every 15 minutes or as deemed appropriate by the patient's condition. Okay? So the vital signs here, you have consciousness, right? Someone needs to be conscious. If they're unconscious, then we have a big problem. Breathing is one of the vital signs. And circulation, pulse and skin characteristics, okay? And now we have here signs of shock. Decreased responsiveness, okay? Something is going on if someone is able to, not able to respond. We have some issue going on, right? Signs of shock. Unresponsive to verbal commands, okay? So you're asking them questions and you're telling them to do simple things, and they are unresponsive to that. Things that a person who's in, normal or at least reasonable condition should be able to do. Next, we have a heart rate that is too fast or too slow, okay? So we have something going on. Heart rate is too slow or too fast. Their condition is at an altered state. Pale, ashen, cool, moist skin. Okay, these are all signs of shock we're dealing with. Weak or no radial pulse, brachial pulse in infants, okay? So these are signs of shock here that you want to look out for if you're dealing with a patient displaying these symptoms, okay? Okay. So measure to treat shock, okay? Control any external bleeding, okay? So if someone is bleeding profusely, we want to slow down that bleeding, okay? This will help combat the symptoms of someone going in shock, or maybe try to help prevent them going in shock or treating shock. Administer supplemental oxygen if available based on local protocols, okay? EMRs in different states have different authorities. Okay, they have different authority in different states. So you have to be aware of what your particular area of practice allows. Lay the patient flat. Okay, lay the patient flat. That's very important when dealing with treating shock. Keep the patient from getting chilled or overheated, okay? Very important. Not too hot, not too cold. All right, this is a scenario that we're going to discuss in person here, okay? You arrive at the home of an older woman. She is sitting at the kitchen table with her left hand wrapped in a kitchen towel. She said that she was chopping vegetables for dinner when a knife slipped and she cut her hand. I just had my knife sharpened and I guess I didn't realize my hand was so close to the food. The woman is pale and there is a large amount of blood seeping through the towel. You also notice a small amount of blood on the cutting board. While speaking with the woman, you notice that she is beginning to become irritable and is having trouble answering your questions. Okay, so that is the scenario that we're going to discuss while we're in person, okay? Remember, she's irritable and having trouble answering the questions. And she has blood leaving. We just discussed in previous chapters how lack of responsiveness can be dealing with possible shock or other issues. So just keep that in mind. Okay, Here's another one. You are the emergency medical responder. As you begin a primary assessment, you verify that the infant is unconscious. Okay? So what do you do from there? You're starting your primary assessment. You're checking for a pulse, a responsiveness. You find that the infant is unconscious. What is your next move? Okay. Glasgow Coma Scale. 3 parameters, okay? Eye opening, that's 1. Verbal response, that's 2. Motor response, that's 3. Okay, this is the Glasgow Coma Scale. And here's a score. A 3 minus coma or death, 8 or less. So 3 or less, coma or death. Okay, that's the lowest. 8 or less, severe brain injury. 12 or less, moderate brain injury. 13 to 14 miles. So you see, as the numbers go up, it's less severe. As the numbers go lower, it goes to coma or death. Okay, and that is the last slide wrapping up this chapter.